And that's how you do it. You start at the head and you work down to the toe.
Once the primary survey, which are all the life-threatening injuries, airway and breathing for us, and by the way, I should have added, included in after A, B, C's for circulation is serious bleeding. So if there was serious bleeding here, once she had airway and breathing, I go to the serious bleeding and stop it. You're realizing if you lose your blood volume, you can't carry oxygen, and then you have the shock problem, as Sandra's mentioned. Okay? So those things are now taken care of. So now we're looking for all those things that she will not die from immediately, but could cause problems hours down the line. So then I go cervical spine, take my fingerprints under the base of the neck, and I just feel here. And for all of you, it's soft and non-tender. So here's my arm sitting here, and it's soft. You see it is sitting here? Or if there's a cervical spine injury, many times that is hard. It feels like a tense, tight muscle. Like some of you at work are kind of, oh boy, you know, rub my shoulders, all that kind of stuff. So it's soft and non-tender. If she is conscious, and I sit here and I say, does this hurt anywhere? And if she indicates there's a pain, then I assume cervical spine, and everything I do is based upon that assumption that there is a cervical spine injury. All right? The first thing is we don't move her. So assuming no cervical spine injury, I come up to the head, and I just put my hands on, and I just manipulate all around, feeling first for bleeding, dampness. She could have a serious scalp laceration right now, and there's no blood anywhere because the hair makes a really good tourniquet. It's a dressing that's there all the time. So I feel for dampness and so forth, and I feel none of that. Notice I'm not wiggling it all around. Then I feel for bumps and indentations. Your head's like a golf ball, has little dimples in it or ridges, but they're usually symmetrical. So if I notice a big bump here or an indentation, I make note of that, and then I start looking for possible closed head injuries or stuff like that as I go down the line. So head. Then I come down, let's look at the face, I look at the eyes. Are the pupils equal? Unequal pupils could tell me there's internal closed head injuries, brain problems. Look at bleeding from the ear, then walk around and look on the other side. Don't step over them unless you trip and fall on them and hurt them. And the nose, and bleeding from the inner ear, way inside, not on the outside of the ear, cartilage. Also another sign of possible closed head injury or skull fracture. Move my way down, check in here, open the mouth, and look for dentures or broken teeth or objects in there. If there are full sets of dentures in place, leave them. Then move down, make sure the trachea is midline. If it's shifted, that's usually a very, very negative sign. And if not line, then if assuming problems, expose the chest. Look at the whole chest. Look for puncture wounds, bruises, fist-sized bruises, and so forth. And then put your hands on the side and just assess equal breathing. Does one hand come up and one hand not move at all? Indicates possible lung damage. And even if she's unconscious, take your hands and squeeze in here to elicit pain. Not real tight, just a little bit of pressure. Ribs are very sensitive. If there is any damage, she will withdraw from that pain, and you'll know there's possible rib bruise or fracture at the maximum or so. Okay, then move down the abdomen, expose it. There are 4 quadrants. Abdomen goes from just above the groin to the diaphragm. So there's a upper left and a lower left. Just lay your hand on gently and press down and release. Abdomen should be soft and non-tender, just like the back of the neck. If you release and there's wincing, on this side could be spleen, so forth, intestinal, liver, gallbladder. Now you're down to the small of the back. Take your hands, go underneath and feel the curve at the lumbar thoracic spine. It should be soft and non-tender, but it's more muscular than the neck. The neck is really soft. And here, there's more muscle mass used for keeping you erect all the time, so it tends to be firmer by nature. Then you're at the pelvis. Take your hands and push out, then push in, and put your hands at the head of the pelvis and push down. This will elicit pain. If you thought there could be groin injury, you expose the groin, same way, and take a look. Then each individual leg, look at the length. Look at the symmetry. Are they look identical? For most of us, that's the case. If one was turned out and a little bit shorter, it wouldn't be bent at the knee because it could be fractured or dislocated at the hip. Then you tell yourself, probable hip fracture. You're not guaranteed to know that. but you would assume it and then treat it. Then take your hands and slide down the cylinder, squeezing. For deformity and pain, does this feel normal? All the way down. Take the shoe off. If she was conscious, we're sitting here, ask her to tell me what toe I'm touching without her seeing it. Have her wiggle her toes. So sensory motor skills, can she feel? That's nerve. Can she wiggle? That's voluntary muscle. That tells you it's good intact. And pedal pulse, if you could do that and know where it is to do. Tells your blood flow all the way to the distal extremity. Then you do the same thing all the way down on this side. Okay? Then I come back up. I take my hands along the clavicles in here, pressing, feeling, squeezing the shoulders. I do each arm. If she was conscious, eventually I take my fingers and overlap them. Let her grab here on the other one, and she squeezes those for equal grip strength, which is a sign, once again, of spinal damage. Do the same hand. Check the radial pulse. Then the side I'm on, I lift this arm up, assuming there's no C-spine problems, once again, and I roll her, grab the shoulder, grab the hip, I roll her to me, and I go right down the whole back. And if you did this and you practiced it, it would take you probably a minute if you didn't talk to anybody about it and just did it. So primary survey, first, airway breathing, circulation including serious bleeding. If there is no pulse, if you started with this person and didn't know and they had no heartbeat, they guaranteed not to be breathing or any of those other things. So you move down to the next stop. And then head to toe, just looking all the time, talking to her, asking her questions about what bothers her and doesn't bother her, right down the line. And then the things you find out during the secondary survey are the things you will treat: splinting, bandaging, positioning, etc., etc., etc. And I can tell you one last thing before we go to skills, if you would. If she was conscious, if she was unconscious and she had good ABCs, as Sondra mentioned to you, anyone lying on their back unconscious, involuntarily, so you're not sleeping, you're not relaxing, but you're unconscious for other reasons, so I can't wake you up, but you still have good ABCs. If you were to throw up, the vomitus would come right up to the back of your throat and stay there. It doesn't come flying out. And then it becomes an airway obstruction. So the position to put them in, as Sondra mentioned, the coma position, put the same arm up again, shoulder, far knee, bend this knee, and roll them right to you. Make sure that knee is here. That's the kicker. That keeps her from rolling on her face or stomach. It's bent. Bend this arm up. This puts her chin at a tilt. When she throws up, all the vomitus comes out of her mouth, lies on the ground. She'll be in it, but off of it about 1.5 inches, and she won't roll this way because that knee stops her. And you have them stacked up.
When you first come upon somebody, you don't know whether they've got a spinal injury. Do you just leave them in the position they are and try to do a primary survey of them? Or?
No. First, are they conscious or unconscious? If they were unconscious and she was tilted or all to the side and so forth, I have to do an exam, and you want to be able to open the airway and so forth. So if you're by yourself, the problem is unbelievably acute. You cannot be successful. Almost you cannot be successful. But there's more than one person, even you being trained and them being untrained. If you take your time, you can hold her head, and then get it straight in line. And that's where you stop. This is the neutral position, chin perpendicular to the ceiling.
So you should do that even if there might be cervical spinal.
If she has a cervical spinal injury from here already, then getting back to here. That's a changing. It's correct. It's like we're changing it.
And what if they're on their
stomach? Excellent point. You roll over on your stomach. So now it needs more than one person. It needs more than one person. Could I have you roll her and I'll hold the head? Now the person, I'm fortunate because this young lady is more trained than I here. But if one of us has to hold the head. Remember, the head weighs, before we get started, like 15 pounds, 20 pounds. So when you turn it, I'm going to hold that head in line with her spinal column. And when it turns to the side, I'm going to be holding it so it's going to take a little. It's not overly heavy. I think everyone could do it, but it's not a feather. If you relax, it goes kink. It's just going to turn. So you don't want the head to yaw or go back and forth. So I stabilize the head right here, and Lois turns her, and I hold her, and now she's on her back.